Good afternoon. I'm honored to be with you here today. In the next 10 minutes, we will speak about intravascular imaging, fundamentals of Ivus and OCT from technician's point of view. My name is Ahmed Qorah. I'm from Fujairah Hospital, UAE. Starting with my agenda, this is an example about the importance of intravascular imaging from our daily practice. This is a male, 35 years old, a smoker. He came to our emergency department as a case of chest pain. He had a history of stent LED few months back. As you can see here, there is some haziness in the proximal LED. So we did OCT for the patient. The surprise was that the stent was massively undersized and malabused. So the last update from European Society of Cardiology in 2024 put the Ivus and OCT for complex PCI in a class 1 level of evidence A. Now let's go for morphology by Ivus. Starting with fibrotic plaque. As you know, most atherosclerotic lesions are fibrotic. Fibrous plaque looks bright on the images, as you see here, brighter than our reference adventitia. Calcified plaques also usually looks brighter than adventitia, but you can distinguish between fibrous and calcified because calcium will obstruct the ultrasound from go beyond, so you can't see anything beyond the calcium. And also it will produce artifact called reverberations. And finally, fatty or soft plaques. Fatty usually is darker than adventitia and soft because it has a high concentration of lipid. Now morphology by Ivus. Fibrous plaque, it has pathological intimal thickening more than 600 micrometers, bright and relatively homogeneous intimal part, homogeneous and darker behind the intima because also of lipids. Fibrocalcific plaque, usually calcium, appears as sharply delineated dark regions without shadows that are typically surrounded by brightly visualized fibrous tissue, as you see here, the fibrous tissue. And the fibroatheroma, it consists of two parts, fibrous cap and necrotic core with low signal that appears dark with no borders. And we have two types of fibroatheroma, either thick cap fibroatheroma or the thin cap fibroatheroma, TICFA. TICFA has, still that this is a TICFA, the thickness of the cap must be below 65 micrometers, and we can appreciate it here. A thrombus, either red or white thrombus. Red thrombus usually high attenuation, it looks dark with the big shadow behind, while the white thrombus low attenuation, bright, and with slight shadow or no shadow. Comparison between Ivus and OCT. The most important to know that OCT has much higher axial and lateral resolution than the Ivus, and the Ivus can penetrate more in the tissue than OCT. Also, the Ivus no need for blood clearance, while it's a must in OCT. Advantages of Ivus: it can give you the ability to image large vessels, evaluate vessel remodeling, overall evaluation of plaque burden. While the disadvantage, it's relatively inferior evaluation of stent malabsorption and edge dissection. OCT can measure and characterize calcium thickness, more detailed assessment of plaque morphology. Disadvantages of OCT: lack of full thickness visibility of the vessel wall because of the penetration, inability to visualize the aorto-ostial junction, and excessively large vessels. This is an example to see there's much big difference between the OCT resolution and Ivus resolution. Even when we compare the OCT with high frequency Ivus. This is for the penetration. As you can see here, we have the same lesion, but it's a TICFA, thin cap fibroatheroma. In the Ivus, you can see the external elastic membrane. and measure the whole vessel diameter. But in OCT, you just can measure the lumen. So when to use which modality? For Monoca, just focus on the yellow items. For Monoca, always go for OCT, left main disease, superiority for Ivus, because you can see the ostium and the proximal part of the left main better. Calcified lesions go for OCT because you can measure the thickness. Ruptured plaque or thrombus, OCT, you can see it better. And thin cap fibroatheroma go for OCT because you can accurately measure the cap thickness. Performing measurements. Plaque burden. The plaque burden is a comparison of the area of the plaque to the area of the lumen in a single cross-section of the vessel. Large plaque burden can occur without flow limitations because of vessel remodeling. Not valid for percentage stenosis measurements, also because of vessel remodeling. Now, stenosis rate. To calculate the stenosis rate, you need a distal reference with normal or very low plaque burden, very small plaque burden, and the most stenotic area in the lesion. Measure the areas, put in the equation, and you will get the results. For this example, Ivus example, the stenosis rate is 67.4, and OCT example is 84% stenosis rate. Stent sizing. You can size the stent by two ways, EM method or lumen method. EM method is a little bit aggressive. You need a proximal and distal reference. Take a mean diameter between them and go round down by 0.25. Lumen method, the opposite way. Take a proximal reference, distal reference, take the mean between them, and round up 0.25. These are examples. This is an Ivus example. As you say here in the diameters, if you look, you will see that the reference diameter is almost 4.3. So the best stent will be in this region will be 4. This OCT, the other side, if you look here, it's 315, 275, so it's around the 3.0. The reference diameter is about 3.0. So the best stent in this case is a 3.25. A stent apposition. The stent is well opposed if the stent strut touches the vessel wall. So when we have a space, like we can see here and here, more than 200 micrometers with a length more than 3 millimeters, we are telling this is mal-opposed stent. A stent expansion. Measure stent lumen area at the tightest point. Compare measurement to distal reference lumen area. And the stent is considered accepted expansion if it's 80% expanded. 90% is fully expanded. This is the stent expansion areas. And I keep this one printed on my machines in OCT and Ivus. So, for example, if you have a 3.0 stent, it's very easy to compare the areas you have on the machine with the parameters here. MLD max workflow. This is for OCT, pre-BCI, M for morphology, look for calcium, length, the length for stenosis, from normal to normal, and avoid landing in TICFA or high lipid pools, diameter, either EAM or lumen, medial dissection that reach the media and take one quadrant arch, apposition, as we mentioned, more than 200 micrometers and more than 3 millimeters. Expansion, 80% is accepted, 90% is optimal. And finally, take-home message. Limitations to use intravascular imaging in general are time-consuming and cost. Trying to find a way to neutralize the limitations and increase the usage of imaging. And from my side, it's very beneficial. It will give you better results. So I encourage to use imaging if possible in every case. And thank you.
Okay.